Good afternoon to everyone. My name is Dan Clinchot. I'm the Vice Dean for Education in the College of Medicine, and I chair the Department of Biomedical Education and Anatomy. And I am pleased to introduce the Burnham Lectureship. And this is actually the 20th lectureship, and it is the John Burnham Lecture Series in the history of medicine and science. And it was established in 2000 with very generous gifts from his wife, Marjorie Burnham. And it was to establish an annual lecture specifically in his honor, and he himself was dedicated to the history of medicine and science. The Department of History and the Medical Heritage Center of the Health Sciences Library jointly host the annual lecture. Since its inception, 19 individuals have been honored as the Burnham Lecturer, and our speaker tonight is the 20th Burnham Lecturer. John C. Burnham was a leading international figure in the fields of the history of medicine and science. He wrote more than 80 major scholarly articles, many of which have been reprinted and are considered classics. He also wrote 10 books and edited 4. 2 have won prizes, and 1 has been translated into Japanese, and 2 have been translated into Chinese. Professor Burnham taught at Stanford and Claremont colleges, and he was the Fulbright Senior Lecturer in Australia at the universities of Melbourne, Tasmania, and New England. He also served as the Tolman Visiting Professor at Bowdoin College. From 2002 to 2003, he was a visiting fellow at Robinson College in the University of Cambridge. He served as president of the American Association for the History of Medicine and held many other offices in scholarly organizations, both in the United States and abroad. He was a fellow of the American Association of the Advancement of Science. He also was the 2014 recipient of the American Association for the History of Medicine Lifetime Achievement Award. Dr. Burnham was a research professor of history and held a courtesy appointment in the Department of Psychiatry at Ohio State. He was an affiliated scholar of the Medical Heritage Center, and we are grateful to his wife Marjorie for establishing the namesake lecture that will keep the legacy alive within the Ohio State University and beyond. And I would like to now introduce Dr. Levi, who will introduce our speaker.
Thank you, Dan. What a great turnout today. 72 of us. Thank you, Dr. Brandt. So I am Scott Levi, Chair of the Department of History, and it's my great pleasure to be here today to help introduce our 2024 John C. Burnham Lecture in the History of Medicine and Science. We're, as Dr. Clinchot noted, we're celebrating a milestone today. This is the 20th year that we have been able to hold the John C. Burnham Lecture. Thanks very much to the generosity of Marjorie Burnham and her family. Unfortunately, Marjorie is unable to join us today, but we are thrilled to welcome John's daughter, Melissa Carlston, and granddaughter, Aria Carlston, who are both here in the audience today. So we'd like to extend our deepest gratitude to the Burnham family for their continued support that helps us to keep John's legacy alive. Now it's my privilege to introduce our distinguished speaker, Allan Brandt, the Amelie Moses Cass Professor of History and Medicine and Professor of the History of Science at Harvard University. That business card must be a very large business card. Where he holds a joint appointment between the Faculty of Arts and Sciences and Harvard Medical School. Professor Brandt is a specialist of the social and ethical aspects of health, disease, medical practices, and global health in the 20th century. After graduating magna cum laude with honors in history from Brandeis University, Professor Brandt went on to earn his MA, MPhil, and PhD in American history from Columbia University. Professor Brandt's accomplished positions at Harvard reflect his considerable influence in shaping the field of medical history. He served as director of the Division of Medical Ethics at Harvard Medical School from 1996 to 2003, director of the Harvard Medical School MD PhD program in the social science track from 2004 to 2008, dean of Harvard University's Graduate School of Arts and Sciences from 2008 to 2012, and he served as chair of the steering committee at Harvard Global Health Institute since 2015. Additionally, he recently served as the interim chair of the Department of Global Health and Social Medicine at Harvard Medical School. My condolences on the chair job. Among his many accolades, Professor Brandt has been elected to the National Academy of Medicine and the American Academy of Arts and Sciences. In 2015, he was awarded the Everett Mendelsohn Excellence in Mentoring Award by the Harvard Graduate School of Arts and Sciences. In 2019-2020, Professor Brandt was recipient of fellowships from the American Council of Learned Societies and the Radcliffe Institute for Advanced Study. Professor Brandt's widely celebrated 2007 book, The Cigarette Century: The Rise and Fall of and Deadly Persistence of the Product That Defined America, focused on the social and cultural history of cigarette smoking in the United States. We'd be here for far too long if I were to list all of the awards that this book received. But two worth noting are the Bancroft Prize for the best book in American history in 2008, and the Welsh Medal from the American Association for the History of Medicine in 2011. He's also the author of No Magic Bullet, A Social History of Venereal Disease in the United States Since 1880, which he published in 1985. This was the first of two books by Professor Brandt that were nominated for the Pulitzer Prize. He's written on the social history of epidemic disease, the history of public health and health policy, and the history of human experimentation, among many other topics. Professor Brandt's talk today is entitled Stigma, Then and Now, Historical Perspectives on Disease, Meanings, and Their Impacts. And we are very honored to have him here with us today. So please join me in welcoming Professor Allan M. Brandt as our 2024 John C. Burnham Memorial Lecture in the History of Medicine and Science.
Thank you so much. I wasn't nervous when I came in, but then when I saw the program and the people who have spoken before me in this series, I suddenly thought this is just it's been a remarkable series, and I'm incredibly honored to be able to speak in it in a way that honors John Burnham's memory. I want to thank Dr. Klinkott, and I want to thank Professor Levi for their wonderful, if excessive, introduction, and just tell you how honored I am to be with you here today. I knew John Burnham quite well from, let me just see if I can get this to, I'm having trouble with the slide, as you can see. I knew John quite well from his leadership in the field. And I have to say, as a young academic earning a PhD, I would go to the American Association for the History of Medicine meetings every year. And John was an incredible advisor and mentor to young academics. But I would be talking in a room, there'd be a much smaller audience than this, and I would see John come into the back of the room. And, it's that feeling of, oh, great, John's here. It's that other feeling of, oh no, John's here. And he would always have the hardest questions for young historians, but always offered in the most gracious and constructive way. And those of you who knew John know that he had just a lightning sense of humor. And the only thing faster than his sense of humor was his intellect. So one always knew that you would get a hard question, and it would be one that cut right to the heart of your work and what you needed to do next to improve it. So I'm incredibly grateful, and my memories of John are very fond. He wrote many books, as Dr. Klinkott pointed out, but these are two that influenced me the most. And I just had a chance to reread How Superstition Won and Science Lost. And it's a book that, as you can tell from its title, is incredibly prescient in the reduction of the authority and the erosion of authority of medical science in an epidemic age. So I urge everyone who's looking for a book to understand our present better to go back to this particular book of John's. Today I'm going to talk about work in progress, and I've been working on it for a while, but I'm writing a book on the history of stigmatized diseases. And all diseases have meaning, but some trigger negative, often hostile meanings, and it leads to problems in their care and treatment. I'm not sure this is going to work.
Mandy, what come on?
I'm technologically challenged. And it's a great photo of John because it captures his warmth and liveliness.
Allan, would you like me to advance your slides for you?
I may have to ask for that kind of assistance.
Yeah, I'll support you.
Thanks, Jim.
Just give us a high sign and we'll advance.
Okay. It's always a group project, so. Okay, that's good. I'm talking about stigma. This is the definition from the Oxford English Dictionary. A mark on the skin by burning with a hot iron, by cutting or pricking. All the associations with stigma are traced back to early ages of Christianity and Christ, but they all are associated with the body in this way that it's a mark of disgrace or infamy, a sign of severe censure, and I think we all have a powerful sense of either at one time in our lives being stigmatized or in another phase of our life sometimes realizing that we have a bias against people who may have certain kinds of differences. And so the study of stigma is really studying complex social processes of how we think about us and them. What is the process of making someone the other? And unfortunately, we see this in society all the time. We especially see it around conditions of the body and diseases. And that's what I've been trying to understand. There are a couple books that have influenced me greatly in this. And some of you may be familiar with the classic work by Erving Goffman, a mid-century sociologist on stigma. And Goffman said that it's one of three things, really, or three related things. It's an abomination of the body in some ways. One might think like leprosy. It is a blemish of character. One might think somebody who is addicted to drugs. Or it's a tribal hatred. And one may just think like, these are the kinds of tribalism where from the very beginning we think of the other group as different, below us, things like that. And the book is really remarkable. It was written in 1963. It still is enormously widely read. I'm prepared to argue it's one of the most important contributions of mid-20th century social science. It's in print, it's read across fields. You can barely find an article on stigma that doesn't cite Goffman. The other books that influenced me came out when I was a graduate student by Susan Sontag, and she used literary approaches to understanding difference. At the time, she was suffering from breast cancer, and there was an extensive literature that kind of blamed people for their cancers. It said they tend to be, psychologically impaired, they're uptight, they can't express affect, and these are the character types that develop cancer. All of these ideas are no longer current in any way, but she felt that you could study a disease and learn a lot about its meanings. And something that I've really taken from her and Goffman, these meanings have extensive implications for how people who experience them are treated by others in the community, but also within medical care and treatment. Thanks so much. Yeah, we're going to get this right. One of the things I want to argue is that one might think, well, I'm interested in disease meanings, and as Sontag emphasized, you can take literary approaches, or sometimes this is called the social construction of disease. How do social forces produce these meanings that a particular disease might have? But one of the things I'm emphasizing in this project is that these meanings have a material and epidemiological impact on people who suffer from these conditions. So we ask, what are the biosocial harms of disease? Disease is not just a simple pathological process. It leads to isolation, stereotyping, alienation, sometimes depression, sometimes stress. But these are all elements of being stigmatized. It makes it hard for some people to actually seek care because they're embarrassed or they're shamed by the disease they might have. And this has the effect of augmenting basic health disparities among populations. If you have a stigmatized disease, you're less likely to get treatment, to have it covered by insurance. And so it creates these gaps among those who don't suffer from these problems and those who do. Some of these stigmas are actually deeply embedded in clinical care. And so it's not like we go to medicine for understanding and protection. For some of these diseases, some of the stigma is actually generated by physicians themselves or the healthcare system. There's a social epidemiology to the stigmatized disease that I want to get at, and it has tremendous impact on our health economy and our economy in general. If we could treat stigmatized diseases more effectively with less stigma, we could reduce the costs of care, I'm prepared to argue, in important ways. There's been a lot of literature and research recently on if one internalizes stigma, it actually does them harm. There's similar literature about race and racism and the impact that it has on the body. So the question that I've been interested in is, how do we make and unmake stigma? Is there something we could learn by investigating the history of these diseases and some of the similarities among them that would give us some insight into what now is a widely used term, doesn't appear in the Oxford English Dictionary, of destigmatization. And we hear about it all the time. Newspapers write it, we see many efforts along the lines to destigmatize diseases because in part we understand their social costs and the impact that they have on patients. But this has been a complex process, and what I'm doing in my project is looking at several of these areas to see if, in a sense, we could de-engineer stigma, that by understanding how it is generated and looking at it closely from a historical point of view, could we gain some insights into better strategies for reducing the stigma for so many people who are affected. So I've really started by looking at AIDS and HIV. And I was a young student and PhD living in New York City during the inception of the AIDS epidemic. And I realized that the stigma of being gay, having a deadly disease, the fear that AIDS generated had led for it to be highly stigmatized. And so I think it could be one useful model for thinking through the issues of how we get stigma and how might we begin to intervene in more effective ways. So this is a photo from 1983. Many of you are born much later, but some of you may remember how vicious in the early 80s the response to HIV was, especially among far-right religious groups, especially among groups that, led with homophobia. And, there was very little being done in the government, in public health, to try to address the problem. And this led to this kind of outrageous behavior, but at the same time, it was really filtered more deeply into American culture and society. And I have a vivid memory of one night. If you lived in New York City at the time, you could get the New York Times on the Saturday night, the Sunday Times on the Saturday night before it appeared. And there was a long article by a well-known science journalist on the first few years of AIDS. And she wrote about what she called innocent victims. And she wrote, the groups most recently found to be at risk for AIDS present a particularly poignant problem. Innocent bystanders caught in the path of a new disease, they can make no behavioral decisions to minimize their risk. Homophiliacs cannot stop taking blood clotting medication. Surgery patients cannot stop getting transfusions. Women cannot control the drug habits of their mates. Babies cannot choose their mothers. And unlike, Jerry Falwell or Pat Robertson, who were leaders in the religious right, decrying gay men mostly who had contracted AIDS. This was like a well-known science journalist for the New York Times, and I had been studying what they called innocent syphilis infections in the early 20th century. And I realized exactly what had happened. I don't think I would have caught this otherwise. But this journalist was saying many groups getting the disease are innocent bystanders, as she wrote, caught in a new epidemic. And what I had explained about this was that if you say that somebody is an innocent bystander of a pandemic, you're really saying somebody is a perpetrator and therefore a guilty perpetrator. And she doesn't mention in this, but she was really saying gay men know, but they're spreading this disease to others. And I had a chance to meet her 10 years later, and I asked her about this piece, and I said, it could imply that gay men were really the sort of knowledgeable source, the guilty perpetrators of the epidemic. And I wasn't really surprised. She said to me, of course I didn't mean that. But one of the things we know about stigma is it can also operate in less than fully conscious ways. And people have biases and hidden assumptions that sometimes drive a stigma. And I would say we have to understand those elements of stigma as well. I was talking at a meeting sort of very early in my career, 1985, and I mentioned the idea of AIDS victims. And there was a young man in the front row, and he popped up right away. I was very surprised, young, naive, unprepared. And he said, "We are not victims. We are people with AIDS." And the incident was shocking to me, although I got a chance to talk to him after my talk. And he was a leading figure in early AIDS activism, a man named Michael Kalin. And this is just the quote that I read you, but I have a photo of Kalin that follows this. Maybe I don't have that photo. Let's go back just one or two. Okay. Well, Kalin got up and, interrupted my talk, which was characteristic of AIDS activists. And I realized that he was right. And people don't want to be identified by a disease. They don't want the disease to be their full identity. So there's been a lot of work in destigmatization campaigns to not say this person is a schizophrenic. It's a person with schizophrenia. And I really learned that at a relatively early time. So when I'm collecting destigmatization strategies, language is often really important. But we go from those earliest days of the HIV epidemic, the 1980s into the 1990s. And I thought, this is a really dangerous time. We're talking about quarantining, not just people with AIDS, but also people who might be at risk for AIDS. And the homophobia that informed the first decade of the epidemic was just intense. But I watched the introduction of antiretroviral treatments, the incredible effectiveness of activism, and I realized that things were changing. And now I'll take the next slide. 35 years after the horrendous protests, the Supreme Court guaranteed marriage equality. And for me, as a historian, that seems like a big question. How do you get from those early days of the AIDS epidemic, which were so painful and filled with anxiety and rage, to the idea that our Supreme Court in 2015 would secure marriage equality? In 1990, I would have thought the chances of criminalization and quarantine were much higher than this as a possibility. And it made me realize that in some instances, historical change can be relatively quick. And so a big part of my efforts right now is to explain this shift. And I sort of have the conclusion that if I could, then, we could possibly think of how to insert interventions that might be truly effective. So I've been thinking about what some of these things that may have changed during this 35-year period might be. And, going back, there were these ideas that whether you could donate to blood, and there were many laws against the donation of blood, but this is another example of the change. We're now seeing the federal government, just in the last 3 years, re-permitted gay men to make blood donations. So this is the question that I have, and These are some of the things I've been thinking about. One of them is language. This is what I mentioned about Michael Kalin. Some of you have probably seen the movie Philadelphia. I recently showed it to my students, none of whom had heard of it, but they left the room in tears. And I think it's a very apt attempt to use film to destigmatize. Kalin, who I met in this meeting, had a band, and he has a cameo appearance at the end of Philadelphia, but he died the year before it was released of HIV. Next slide. One of the things that was debated intensively, and even though it's not that long ago, there's a tendency for all of us to forget that there was a giant debate during HIV about whether the press should write in an obituary that someone had died of AIDS. And there were many young men dying, especially in places like New York and San Francisco, and it would say, they died after a brief illness. And everyone would speculate, did they die of HIV? And some journalists thought it's important to report these deaths as they are, and others said it's a gross violation of privacy. Again, I recently asked my students, do you know who Rock Hudson was? No one knew. But Rock Hudson was a leading film actor, a leading man, kind of what Hollywood might have called a hunk. And he was one of the first celebrities to announce that he had AIDS. And it had a big impact. Even though he didn't come out, there was wide speculation. Now there's wide documentation of his being gay. But this had a giant impact, and especially on things like people sharing their diagnosis. And these are forms of what I think we would sociologically call coming out. And it's very hard to reduce stigma if individuals who are affected don't want to come out. And it was a very interesting thing. I was a young faculty member at Harvard Medical School in the 80s and early 90s, and many gay physicians came out during that period. And before that, they had seen no particular motivation, or they had feared certain kinds of discrimination. But during that period, I think, when so many people, so many young men were sick and dying, they could no longer not reveal their sexual orientations. And so this had a very big impact. If we're collecting potential destigmatization strategies, it would be hard to underestimate the impact that activism had. And I think this is true. I don't think I've ever seen destigmatization without some form of activism, especially among those who are most affected. And this became very characteristic. People took to the streets to demand attention, research, care for people who were suffering. There was brilliant communication strategies used by groups like ACT UP and the Gay Men's Health Crisis. And I hadn't known this before I really began to explore it, but they had put together a communications design team to come up with both, mottos like this, but also strategies of communication. So this makes me add that to my list. Living in New York at this time, silence equals death was on every piece of plywood around any building that you could find. And the pink triangle was was from the Nazi period, when If Jews had to wear yellow stars, gay people had to wear the pink triangle. And so they had usefully discovered these legacies of stigma and hate and used them very effectively in their communications. This is the AIDS quilt, first in 1985 when it was just getting started, and then in 1987 on the Capitol Mall. And in 1987, 500,000 people visited the display of the quilt in a 2-day period. At this point, it weighs 54 tons, and it's part of the AIDS Memorial that just opened in San Francisco, where it's held. It still is sometimes sent around the country. And I have to say, in some ways, I didn't really understand how the quilt works as public art. But people walked around, they would show their quilt to one another. The quilt had people who obviously were gay men, but it had many people who had died from other transmission of HIV, people who had gotten AIDS from blood banking and other things. And it created a sense of solidarity among people who might have felt quite differently. And it led to people stopping, asking, how did you get it? From whom did you get it? And really focused on shared grieving. And it's a remarkable thing to see these photographs from that time. So one of the things I'm thinking is public art is, again, an opportunity, and using it really creatively and brilliantly as it was used here had a potential element of reducing the stigma that had been so harsh just 5-8 years before. Art was used in many ways. None of my students know Rock Hudson, but they've all seen Keith Haring's artwork on T-shirts and Uniqlo and other places. But Haring had a big impact, and he was associated with ACT UP, and he did a whole series of art specifically related to the epidemic. This was done in 1989 as a poster for ACT UP, when Haring already knew that he was infected. He died the year after this poster was produced. This is a photograph that one of the great artists of the AIDS epidemic took, Dave Wonarovich, and it's untitled. He'd done it in 1994. It captures this sense of despair that was so deeply part of gay public art at the time. He'd photographed it at the Smithsonian. It's from a diorama that looked at Indian practices of animal capture and use of meat. And Vonarovich died the year after this photograph was displayed. If you look, it's also on a U2 album from several years later. And there was other art. There was photography. Nan Golden, who today is a very vigorous opioid stigma activist, had a multimedia art show in New York. Many of you may have seen Tony Kushner's Pulitzer Prize winning Broadway play on homosexuality and HIV, Angels in America. But to understand this, you have to look back even a little bit farther to see things that happened before the inception of HIV around 1980. And one of the things that early gay activists had done was to remove homosexuality from the Diagnostic and Statistical Manual of the American Psychiatric Association. And there was a deep campaign. And it's an interesting thing because early in the 20th century, homosexuality was almost always criminalized. And if the police caught somebody in a park or in a public place in a gay act of sex, they would typically go to jail. And so moving it to a medical category presented some bit of a relief from the idea that you have committed a crime. But by the 1960s, 1970s, medicalization, or this medical diagnosis, was a source of real suffering and harm to many in the gay community. And they worked diligently to really look at the science, to have it removed from these manuals where it had existed before. And I'm not much for historical counterfactuals. I don't think John Burnham would have liked historical counterfactuals. But it has occurred to me that if this hadn't happened in 1973, that by 1983, with the rise of the epidemic, it would have led to much deeper sort of, these people are sick, and now their sickness is threatening our society. So these types of interventions were crucial to the potential destigmatization of AIDS. And I think all of these things link up in a certain way to beginning to understand a rising tolerance for people who are gay and a reduction in the stigma of HIV. I wouldn't want to de-emphasize the role that effective treatment played, but I would say that if one were just to say, as Susan Sontag had sort of said, if we find the cure, there will not be any more stigma, turns out to have a number of problems with it as well. Here are some of the other examples of containing and reducing stigma that are part of my work. This is a group of women who are marching for breast cancer, late 1990s. And if anyone experienced breast cancer or know people who had breast cancer in the 50s and 60s, it was almost never discussed. And that's kind of the moment, the transitional moment that Susan Sontag wrote about. But these are slides from 1974 when Betty Ford courageously announced that she was being treated for breast cancer. So I see this again as a form of self-revelation with the idea of resisting shame in order to educate and inform and in some ways destigmatize. And a number of women announced their breast cancers around this time. Nelson Rockefeller's spouse, Happy Rockefeller. There were books, and Betty Rollins wrote a book called First You Cry. These were very powerful, but it's hard to imagine the previous slide without understanding this particular strategy of destigmatization. Audre Lorde, a famous African-American poet of the late 20th century, wrote, "My silences had not protected me. Your silence will not protect you. But for every real word spoken, for every attempt I had ever made to speak those truths for which I'm still seeking, I had made contact with other women while we examined the words to fit a world in which we all believed, bridging our differences." And this is in her book, The Cancer Journals. I just reread this, and one of the things that characterized Lord's approach to being treated for breast cancer is that she didn't want to wear prosthesis. And she thought that would violate some way. That's what Irving Goffman sometimes called covering. And the idea that you have a stigmatized condition, but you try to pretend that you don't. And so Lord made a very passionate argument that she didn't want a prosthesis. I think the ethical and social issues are quite complex because people don't want to have the identity of their disease. But on the other hand, and they should be able to seek relief from that. On the other hand, she wanted to say that her body really represented at that time who she was. So that remains a kind of tension in this literature. This is a slide from 1990. 2 school buses, each with 50 individuals who used wheelchairs, were dropped at the steps of the Capitol. There was no access possible for them other than to crawl up the steps, and that's what they did. And again, this is an activist approach, communications. It involves a lot of things, but was very instrumental in the passage of the American with Disabilities Act in the next 2 years. And the reason I have the other slide is many of these social movements and activists for destigmatizing saw their work as a civil rights issue. And they often referred to Martin Luther King, and you see this in this disability activist slide. The ADA led to curb cuts, and they're such a natural part of our landscape today that we rarely think about their social history. But I've been encouraging people to write about the social history of a social change like curb cuts. And what it leads to is seeing people who have a disability as part of our urban and suburban and other cultures. And before that, people who used wheelchairs were almost never seen on the street. So this is a technical shift, but it also represents that integration and proximity are a critical issue of destigmatization. The big machine on your right is a curb cutter, and it's a technology that didn't exist until the ADA required states to make curb cuts. And so I don't know if any of your kids ever read Richard Scarry books and identified all the kinds of big machines, but a curb cutter has a giant impact on destigmatization. This is these are prosthetic limbs. The first one is from the First World War. The second one is from the Second World War. And the last one is almost a contemporary artificial limb. And the idea originally was build a limb that looks just like a human limb. And you see this in the World War II one, make it the color of skin, make it so people might not know that you had lost a limb. And then in the most recent phase, I go to the grocery store and I see people with artificial limbs wearing shorts. Sometimes they've decorated them. And I see these as elements of self-revelation, they now are the source of sometimes admiration and respect as opposed to stigma or some idea of being other. These are two wheelchair dancers, and I don't know if they're really just quite remarkable. This is them performing at the Whitney Museum in New York. They go by the name Kinetic Light, and you might have an opportunity to see them sometime. Their names are Alice Shepard, who's in front, and Laura Lawson, who's in the back. And Shepard wrote, "The power of art lies in our ability to view it outside assumed ideas about the body." And she is also what's now called a crypt theorist, similar in some ways to gay theory, queer theory, and just a remarkable notion of the body's possibilities as opposed to their limitations. So the question I've been asking are, what are the implications of these types of interventions and how they are put in order? So there are many interventions, but part of my assumption is they need to be chronologically related and appropriate to be genuinely effective. And how might they be utilized to reduce what I'm calling durable stigmas of mental health, addiction, obesity, and others? And this just lists some of the things, and I realize that you could say, well, these are all things, we should be doing all these things. But I think opportunities for destigmatization are very contextual, time sensitive, and part of what we need to do is figure out what comes first or second before we think about things that are third and fourth. The campaign for marriage equality was incredibly strategic and thoughtful about what states do you go to first, how do you create momentum for change. And I'm sure people have other things to add to this list, but certainly be eager to hear in questions. I've been taking a look at the opioid crisis because it seems to me to have remained so highly stigmatized, and the idea of responsibility, othering, and so on. So I've been thinking about this, and we see some of these strategies that I've identified being utilized now. Change the language of addiction, don't use the term addict in the newspapers, try to think about using the term that this is somebody with an opioid use disorder and forms of medicalization. One of the things I saw in preparing for today is that the New York Times had published an article about gay cruises in 1974, and the Schultzberger and the editor, Abe Lowenthal, when they saw it, they went crazy. They said, we don't use the term gay, we only use the word homosexual. And it didn't change for 15 years, well into the AIDS epidemic, that the editor of the Times changed the policy and said, from now on, you can use the term gay to identify people who had previously been identified as homosexual. One of the strategies with drug addiction has been to say it's a disease. One of the strategies has been to say it's a brain disease. I'm not sure how effective the notion of calling mental illness a brain disease has really been. One of the activist groups, the National Alliance for Mentally Ill, said if we turn this into a biological disease, people will be more sympathetic. But it has not always worked and sometimes actually done some harm. We have effective treatment, so thinking about that, but it's really interesting, as opposed to saying we have medical treatments for a number of the substance use disorders, we say we have medically assisted treatment. And it has occurred to me that we're saying something else, like we have to do other things about these people other than to just treat them. The data today, and fortunately, opioid deaths have leveled off just slightly since the intense years of COVID. about 1 in 10 people who are addicted to an opioid actually get any treatment at all. And it's just a striking aspect of health inequities in our country, where we have effective treatments and people who could benefit from them and people who have been successfully treated, but only 1 in 10 gets treatment. One of the things that people are exploring is reporting in obituaries that, this individual died after a long period of a substance use disorder or addiction. And I think this has been really quite effective, because if people are isolated and they can't say what has happened with the loss, it can be incredibly discrediting. And so I think this was one of the things learned a bit from AIDS activism, is that numbers don't communicate the real personal familial losses of loved ones. And so I had a student who's been studying obituaries as a destigmatizing strategy, and she has spoken to a lot of people who have had losses about the reasons they wanted the obituary to be clear. Decriminalize diseases. And as some of you know, many local police chiefs have worked to keep juveniles who are addicted out of the criminal justice system and get them treatment if they can. This is an announcement for a movie that was on Netflix, Heroin, and I recently had a chance to see it again, and one of the fathers, this person in Massachusetts who had lost a child to an opioid overdose, said, "Everyone in my community would be bringing me casseroles now if my son hadn't died from an overdose." And you get the sense of isolation, despair, and the real harms of stigma that I'm trying to develop strategies to reduce. Part of it has been protest, and there have been really successful political protests against about removing the name of the Sacklers, especially in academic institutions and in cultural museums. The Metropolitan Museum of Art removed the Sackler name from its building. The Louvre did. Tufts Medical School, which was named for the Sacklers, took it down. And I had a group of activist students who I was advising at Harvard. And Harvard has a denaming policy now, so you can apply. They did an incredible job. They wrote a 35-page, highly cited paper about the harms that the Sacklers had committed and the affront of having people in the university see their name on our museums. And the committee just acted and decided not to take the name off. My students were incredibly disappointed. Ann Golden came to Harvard to protest, and these are parents of overdose victims protesting again about the Purdue and the Sacklers at a court case. One idea that my students had pushed was the idea that every institution has many AED machines to try to treat a heart attack emergently in our buildings. I'm sure all of your buildings here have them too. And they suggested that they could put naloxone, Narcan, which is an immediate treatment for an overdose, into these AED boxes. It wasn't just their idea. Some institutions have done it. But again, they wrote an extensive proposal to the Harvard administration asking them to do this. It's inexpensive. Most of these AED machines, if you open them, it calls 911, which is exactly what you would want. And they told them that there really isn't a opioid problem at Harvard, and they didn't want to do it. But these were in dormitories where no one has, virtually ever had a heart attack. But the administration refused to do it. And I explained, you have identified stigma. That is how it works. And they're still working on this. This is my last slide, and it was the slide that I asked to be put on the poster for today's lecture. And Nelson Mandela, when he was president, hadn't done much about the AIDS epidemic in South Africa. And some of you may know the story. There was President Mbeki who denied that there was AIDS in South Africa. Many hundreds of thousands died as a result of that. But after Mandela had been president, he lost a son to AIDS, and he became a vigorous AIDS activist. And he's here with Jackie Achmont, who remains alive but actually is HIV positive and has been for 20 years. But there was something about saying, we are all HIV positive until none of us are, was an act of identification and solidarity, and the idea of, rather than discovering more differences, discovering ideas of basic humanity. So I want to end by just saying that these processes of stigmatization are in some ways like any problem of division, polarization, and understanding the connection that we all have to somebody who suffers from a stigmatized disease is ultimately the goal that all these strategies might in some ways address. So thank you very much. I'm happy to take some questions.
Thank you so much, Allan, for such a fascinating presentation. We're going to do a Q&A now, everybody. I'm going to pass the mic around. Eager hands. Thanks for bearing with us about the technology.
We have the same problem. Just when you think it works, it doesn't. In talking about stigmatization, I think of the seemingly increasing numbers of Black women and their morbidity and mortality rates seem to be increasing all the time. Can you address that?
Yes, I'd like to, because I've been having a discussion. I have some, but that's great. Thanks so much. I'm very interested in that because there are some people in the stigma studies world who say, well, stigma is the big umbrella, and then you place racism and other forms of prejudice, discrimination under it. And I haven't wanted to do that. But what I'm learning really is that if people suffer from racism and then you add a stigmatized condition, then it's amplified in very important ways. So I've learned a lot from the literatures on structural racism and how it's generated for thinking about what we might call structural stigma. But there's just no doubt that, the rates of infant mortality, maternal mortality, HIV, and sometimes when conditions like this become highly stigmatized, they also become invisible. And so part of the idea, and there are many interventions with the media, but I don't think generally people are aware of these kinds of, incredibly vicious disparities that people are experiencing. So again, how do you think of strategies to make a problem visible in order to begin to address the discrimination, prejudice, stigma, and often hate that underscore it?
Do you think we're doing better? Oh, I'm sorry.
Yeah.
Do you think we're doing better with our medical education?
I think we are, but there's so many areas to educate physicians better. And one of the things I think is I taught medical students my whole career, and they start out with very broad notions of the public good and service, and sometimes medical education has almost like a desocialization process where we ask medical students to be so focused and so, directed towards a field or a specialty that they actually, in some instances, lose part of their conviction during medical school. And so my colleagues and I are, working against that. But I just taught a class in my Stigma class on obesity, and it's very interesting. People who suffer from overweight, report over and over again the humiliation and shaming of visiting their doctor. And so a lot of people in the area of fat activism are, incredibly hostile to medical intervention. And that can be very unfortunate, I think, because there are strategies and interventions, and it could be really helpful, but it's become so toxic that, in a way, you have a community that says, we want nothing to do with medicine. So these are really important examples. We could do way better with better curricula, more attention, and the kind of medical education work that Dr. Joe Cott is thinking about, but we're often at the margins of medical education.
I'm interested in the fact that you didn't say anything about blindness. And as I grew up, I remember seeing the white and red sticks.
Yes.
And somehow that seemed to be honorable rather than stigmatizing. But I'd like to hear what you have to say about that.
It's a really fascinating question, and in my larger work, I'm quite interested in blindness. And I think you're right, there was always a lot of sympathy for the blind, but not much compassion or empathy. And it was for this reason. The blind are often, people who are blind, I should say, are often highly isolated, and more than many other stigmatized conditions. And I did this one minor intervention. I have students who are all looking for new creative interventions. So on my business card, I had learned on the web that some people get Braille on it. And so I put my information, both printed, but also in Braille on my, and it's been a kind of social experiment for me. I give it to somebody and they realize it is Braille, and they realize that I have sight. And it's like, why did you do that? And I see it as a tiny act of saying, we don't think about people who are blind. We don't see them that much. They have trouble being out and about. And I think there are certain things with the ADA that have really helped people who are blind get access to, many institutions and opportunities that they previously didn't. But it's one of the most isolated stigmas that I think I can identify. There's some great memoirs now emerging, and I'm interested in narratives of stigma from individuals who have experienced blindness from birth or had sight until an accident or an experience, and how they think about negotiating the world. But it still is this kind of notion of we don't see people who are blind enough to really take advantage of their skills and talents and incredible qualities. And they have unusual qualities that many of us don't.
Well, the other side of the coin would be destigmatization. And perhaps the best example of that was 50 years ago, a book that I'm sure you're familiar with, The Myth of Mental Illness. And I had the opportunity to hear the author present when I was at the University of Kansas Medical Center. And I asked him, I said, well, what about chronic intermittent porphyria and the behavioral attributes associated with that? Is that a myth of a mental illness? And the answer, he had to admit, was no. In other words, destigmatization went so far as to say that all mental illness is basically a myth.
Yes.
And of course, now we know that there is very, very strong evidence associated with various types of mental illness. So I think that one also has to think about the harm that might come from destigmatization, as well as the harm that comes from stigmatization.
It's a really interesting point, and I have to say, I know this work, and I've studied Dr. Zaz, but I never really thought that saying there's no such thing as mental illness was a destigmatizing approach. And I realize that some people say, oh, well, there's a lot of variability and things, but I think it was harmful to people who had mental illness now, and the anti-psychiatry movement was largely abandoning people in a way that enhanced the stigma. So, but I think you're absolutely right. And what I'm amazed about is, we might think, well, people are stigmatized because we can't really treat them effectively. And I sort of take the other position. There are many things that we can treat effectively. And by effectively, I don't mean cure, because most of us who have any kind of medical issue know that we're unlikely to expect a cure for just about anything. But we can, reduce the suffering. But sometimes, the stigma is such an inhibition to care. And it's really too bad, because for mental health issues, for substance abuse issues, people really aren't getting the advantages of medicine, in part because the conditions are so highly stigmatized.
Hello. So I have alopecia, and I am part of a support group of many other people around the world who also have alopecia. And it's a personal fascination of mine with the destigmatization of diseases that do not have a lethality attached to them. Like, for example, HIV/AIDS has a death toll that we can calculate. For example, obesity can even do that. But for things like vitiligo, alopecia, things that are very heavily stigmatized due to their visual nature, they don't have that death toll unless you count suicide as a possible thing to that. How do you go about that? Because that's been a thing that we've personally been trying to figure out within our own community, and honestly, I find this topic really interesting, especially considering how different, I guess, it is from these other conditions.
Yes, I think, many of the most highly stigmatized things are visible, and there's a number that are not. And in some ways, people have used strategies, often, exclusionary, groups that support one another but don't really address the stigma. And I think for a condition like alopecia, there's just, there is a basic sort of knowledge, awareness set of issues. And so sometimes that's a place to start. People need to understand. They need to see that people with alopecia are just like the rest of us. But there's such a basic notion of trying to other and identify the other. And I was talking to my class about this recently, like one of the first things we learn as small children in school is that, and I've watched this on playgrounds, they say, oh, well, that kid is fat. Those are the fat kids. And they get bullied from a very early time. And it occurred to me, like, a very good question is, like, where do kids who are 4 and 5 years old already have such a notion of wanting to create others and obstacles? And I think that's a failure of early childhood education. And the more kids learn and are proximate to people who they might have thought were others, the potential opportunities. I think a lot of things like what you're saying about alopecia, these are things that can be understood when somebody has alopecia, can be explained to people but it's often not in a way that just encourages dismissal and fear. And we fear the other, but the other's just like us. And I think, that I learned from Goffman and others. He starts the book by saying, we, they, them, us. And then by the end, it's like totally obscure which side you're really on. And it's not much noticed when people read it, but, in that way that we're all subject to being different, we need to have more empathy. And one of the ways that I'm defining stigma now is just basic failures of empathy. And we're learning more about the characteristics of empathy, and I think we can learn about it historically, but certainly through psychology, and finding strategies that make us find ourselves in others and care about that, as opposed to, the kind of primal notions of tribal others is sort of where this is. But I don't really have a clear answer for you, but I wish I did. But I do think, where people begin to lose their sense of stigmatization is in getting to know people who are different from themselves. So we should talk more.
Thanks so much for a really interesting talk. My question is about stigma and mental health. And one thing I've noticed as a psychiatrist that has come up over the past several years is this idea of seeking certain diagnoses as being sort of higher status as opposed to others. And a lot of this seems to tie back into social media and online communities and even influencers. And so my colleagues and I see a lot of people seeking certain diagnoses that are not necessarily appropriate, right? And when we see the information that they've been given online, there's a lot of misinformation, right? And these individuals, are seeking help, right? And so they are not inhibited in seeking help. But I wonder just what you think about kind of this idea of there are certain illnesses that are higher status, right? Especially within mental health, and the idea that people are sort of going out and seeking certain diagnoses and seeking to belong in certain communities, and how that affects stigma.
Could you just give me a quick example of like a higher status mental condition?
Yeah. So recently, a lot of young women have come in with a self-diagnosis of autism. And that seems to be a diagnosis that has a big online presence and helps people, the way it's presented online, it helps people to feel really understood and validated in the things that they maybe feel uncomfortable about with themselves. Some of these individuals may well have autism, others do not, right? And sort of in seeking to join this community, I think as providers, we struggle with validating the distress, right? While also wanting to provide accurate information. And I feel like we are up against this mountain of misinformation, especially on social media.
Yeah, it's a really fascinating question, because I have seen just in the last few months, especially adults saying, I just got diagnosed with autism and everything's much better for me now because I understand myself. And, I think we have to see that as, and there are traditionally categories of diagnosis that provide an opportunity to have, a secure sick role, which might protect you from other kinds of things. But I do think with, social media is both potentially a tool for destigmatization, but it really can lead to the kind of isolation and suffering that are more characteristic of stigma. But I think there are a lot of people who are unhappy and they have certain kinds of experience, and there always has historically been a relief when some healthcare provider or healer can say, I'm putting all your things together and here's what you have. And that can be a relief because it's named, it seems like people know what it is, it seems to offer some protection from these being discrete bad behaviors. So I do think that's an element of what we sometimes see going on, especially around certain kinds of conditions. I've been wondering, and it's related to your question, like, does the term neurodiversity reduce the stigma of having some form of autism, or, there's a language to all this, someone's on the spectrum, and it seems to, that now we understand, but it often doesn't lead to the kinds of reductions in stigma that we're really seeking. And
especially when they're millionaires.
yes, but I follow the news really closely on these things, and the reaction to Governor Walz's son at the Democratic National Convention is like, that's data for me. And I can sort of say, that may sound very, unsympathetic, but I'm watching these things as determinants. And, when you see people making fun of somebody who's disabled or ignoring them or, not interested in that as a problem. And you saw this kind of out of the gate reaction from some to Gus Walz at the Democratic Convention that is all about, these core affects of stigma and shame and humiliation and,
I just want to make an observation.
Yes.
I traveled the country, United States and Canada this summer in my car, and in the rest areas I saw boxes which dispense medicine against overdose.
yes.
So,
Getting
getting a little bit opened up a little bit more about the stigma.
Yes, and we have cities where you can get access to overdose prevention drugs, and and people who use drugs use these medications. But one of the things that your question raises is about what we call harm reduction, and a lot of people feel that if we provide mechanisms of harm reduction, like clean needles or Narcan, as you're suggesting, that we encourage these bad behaviors. And so the literature on harm reduction is very tied up with the literature on stigma. And, why can't Harvard students put Narcan in AED boxes? Because Harvard was concerned that it would be saying to students and parents, we have a drug problem here. And what it was really saying is, there's a medication that can save people who have had an overdose. So when you really do the calculus on that, it's saying, there are people just not worth saving. And, it's been like this. It's very hard to get methadone. People think methadone is, just continues the addiction. I was teaching about obesity. I mentioned this, and we were talking about GLP-1 agonists. And, could that reduce the stigma of obesity? And one of the students said she had a friend who was about to go on the drugs, but then somebody told her it was cheating. That our assumptions about people who are overweight is that they're undisciplined and they haven't learned how to take care of themselves, and that they should diet and exercise, even though we know how difficult diet and exercise are. So these are discussions that I don't think people necessarily say this is about stigma, but in the end, it's about making a moral judgment about somebody who's suffering.
Hi, thank you so much for this talk, and it gave me so much to think about, and particularly I just really love that you ended with kind of empathy and human interdependency. And I have, I guess it's a comment that I'm hoping you can respond to. So I'm a medical anthropologist, and I do ethnographic work with insulin affordability activists, both here in Ohio and in DC. And something that I notice among these activists is, I think that stigma against diabetes is what you were describing as durable stigma. I mean, 2 weeks ago on Saturday Night Live, I heard a joke about diabetes, right? And these activists, and my question's, I guess it's about kind of the affective charge, because we're talking about how celebratory, I think we're celebrating treatment activism and patient activism. These activists are confronted with people who are telling them that their lives are not worth it, that insulin should remain unaffordable, kind of calling into question, it's an existential question for these activists. And that movement, I think, is nascent. I think it's at the beginning, but it's hard, it's exhausting, right? And it's, it's a lot of work. I think it contributes to psychological distress. And so I just wanted to, I just couldn't, I was thinking about that while you were talking, and certainly all of these activists are, there's just, there's so much that goes into having to do the work of being an activist while also being sick.
Yeah, I think, I agree with, everything you said. I guess I do have the idea from observing some activist groups that they're with people who they identify with and who they can develop substantial relationships with. And so some activists get some social opportunities and psychological support in their activist work. But sometimes the idea is like, how are you going to solve this problem? And, and part of what I'm saying is these problems are complex. They exist across many different elements of politics and economy and moral beliefs. And so the question that I'm often talking to activists about, and especially my students, is, can you think of something that would be good? Can you think of something that might, at the margins, reduce the oppression that stigmatized people feel? And, I tend to look at things like what happened with HIV, what happened with breast cancer, as, it didn't all happen at one time. And most activism that's really been successful, we're often talking about 20, 30, 50-year frameworks to see a change. So, it's better for people to have modest expectations than over expectations. And one of the advantages of activism is you're with other people who care deeply about the concerns that you have. And, ironically, if you read Goffman or other things, most people with stigmatized conditions have been very isolated and with other people who have that condition. And I think that Goffman, although he doesn't articulate this, understood that that's better than the opposite, where people who share a, disfavored identity can't find one another. So, so I like to think that thinking together with people who are suffering in ways that are familiar to you can lead to small interventions that can become bigger. But I think you're right, it's incredibly challenging and it can be demoralizing.
I know we still have some more questions because we have such a thought-provoking topic here brought by Professor Brandt. Thank you so much. Unfortunately, we are out of time. But thank you again to Professor Brandt. And thank you all for coming to the 20th John C. Burnham Lecture. Thanks, everybody.
Thank you all very much.